Hi, friends. Welcome to the next edition of 5-Minute Recap. The residents arrived at the diagnosis of HELLP syndrome by using only 18 of the 20 questions allotted. And so, again, they did a fantastic job. We presented them with a 34-year-old female who presented with nausea and vomiting. And immediately thinking of a woman of childbearing age, they asked about the possibility of pregnancy, and information was revealed that the patient had actually given birth to a normal baby 1 week ago. And 1.5 days ago, she started to have abdominal pain and now has intractable vomiting. Then the residents quickly asked about vital signs to see if the patient was stable. It was discovered that she was tachycardic, but also had hypertension as considered in a woman recently postpartum and in the peripartum period still. And they also quickly asked about labs, here discovering that the patient had evidence of dehydration with hyponatremia and acute kidney injury, elevated white count, anemia, and certainly thrombocytopenia, all of which are concerning. At this time, her liver function tests were actually fairly normal with the exception of an elevated bilirubin. They also discovered that the patient had proteinuria and ultimately discovered that the patient had evidence of hemolysis, most importantly, noticing that the peripheral smear demonstrated schistocytes. With this information, the residents developed an excellent differential diagnosis. Before they found that the patient had hemolysis, they had come up with a very broad differential, including appropriate things like endometritis, preeclampsia, other liver pathology, and postpartum cardiomyopathy, thinking about a patient who is in the peripartum period. So, with the discovery of hemolysis, their focus became more on etiologies that cause hemolysis, like HUS, TTP, HELLP syndrome, and DIC. They went on to ask further questions to help clarify the diagnosis, including asking for a CT scan and blood cultures, which were unrevealing. They decided to call a hematology consult to discuss concern about TTP and whether the patient needed plasma exchange. But with the findings of a normal Adams TS13 level, as well as a normal echo, worsening liver function tests, and vital signs which remain unstable, the residents felt confident saying that this patient likely has HELLP syndrome. Supporting their diagnosis were things like elevated blood pressure, the fact that she had hemolysis, the fact that her liver function tests increase on day 2 of admission, and certainly she's had low platelets, which have been decreasing from 96. And so correctly, they did arrive at the diagnosis of HELLP syndrome. The one thing that we felt the residents missed here was a chance to consult OB or MFM colleagues. They did appropriately consult hematology, but consider in any patient who is pregnant or even in the postpartum period to consult your OB colleagues. They have much more knowledge about these conditions and can help you think about the appropriate diagnosis earlier on in the patient's case and to help start treatments which may be helpful for this patient from getting worse. And so consider calling OB in a patient who's presenting like this. So I wanted to discuss a little bit about the spectrum of preeclampsia to eclampsia. As you know, preeclampsia is a condition defined by hypertension, proteinuria, and edema, and it becomes eclampsia when preeclampsia exists with seizures. So many people wonder, well, where does HELLP fall on this spectrum? In fact, while HELLP syndrome is often considered to be somewhere on that spectrum and affiliated with preeclampsia, it can be independent. And so you must always consider, even in the absence of preeclampsia or eclampsia, in any patient that demonstrates hemolysis, elevated liver enzymes, and low platelet count. HELLP syndrome can also occur in a partial manner, meaning the patient does not have to have all 3 of these findings and can have any one or more of them. The most common being low platelet count. And so any patient that's pregnant or in the peripartum period with thrombocytopenia should be considered for HELLP syndrome and worked up further. So finally, as internists, if the patient is still pregnant, we may encounter her in our medical ICU if she is being observed. In pregnant patients, delivery is the treatment of choice in a patient who's pregnant greater than 34 weeks. Between 32 and 34 weeks, conservative treatment to get her to 34 weeks is preferred. Less than 32 weeks, we do prefer conservative treatment because delivery can be more dangerous. The only conservative treatments that is available are corticosteroids, bed rest, and IV fluids. And so, if these things, the patient's condition or labs worsen, then delivery is the only method to help the patient from getting even more worse. And so, in a patient that's postpartum, like our patient here, HELP treatment is really only supportive. We can give the patient magnesium or put her on a magnesium drip. We can help control her blood pressure with appropriate medications, and we can help diurese her if there's pulmonary edema. Of course, if the patient's hemoglobin is low enough where she's hemodynamically unstable, you may consider giving additional packed red blood cells and additional platelets. Though in a process like a MAHA type process, those things are sometimes contraindicated. Again, recall here that HELP syndrome has a pathophysiology that's rooted in abnormal placental and maternal circulation, which results in endothelial damage and a MAHA type prothrombotic process, which causes shearing and a hemolytic anemia. And so that is our brief overview of HELP syndrome. I hope that that was helpful. Thanks for watching.